can't imagine staring at my relative.
Yeah, I must have stopped back and I'll just say goodbye to you now.
Want me to put slides bigger there?
Okay, I think that's the music.
Right. Yeah. Yeah. See you tomorrow.
Please, neither to reconnect ice skating.
I'm not ice skating, don't worry, I will not be ice skating.
Fine. Yeah, so I'll well, yeah, but you can come to the ice, come, it'll be funny.
I'll stand there with Joe heckling.
It'll be so funny, yeah.
I literally broke my wrist outside of the skate.
So I'll just be like.
He broke his wrist last time.
I broke my wrist last time, so if you don't break a bone, you're literally doing better than me.
I think I'll see you guys for Christmas then. Sure. See you later.
See ya. Okay, well, it doesn't look like anyone's on the Zoom. I'll share the slides anyway.
There's no one else.
Well, we did start late, to be fair. Which
I'm happy.
yeah, oh no, I'm more than happy to do what I guess this is tutoring now. No, that's all right. Okay. I'll share the screen anyway, just in case anyone joins. There we go. So, welcome to our last part in the teaching series. For semester one, surgical related teaching series for semester one, vascular surgery. So my name's Tim. I'm on the 5th years at Preston. Got an interest in vascular surgery. So this is a sort of quick overview of everything you should need to know. Finals, vascular surgery related, and then maybe a little bit more. So this way the session is going to work, we're going to do a quick run over of vascular anatomy, a quick delve into acute conditions, a guide on recognizing different kinds of ulcers, and then chronic vascular disease and chronic vascular conditions. Start with the anatomy. The key to vascular anatomy really is the aorta. It's the key blood vessel that runs through the body. Starts at the left atrium, as you'll know. Comes up, you get the ascending aorta. Here becomes the artery of the aorta, descending aorta, thoracic aorta. First branches are the coronary arteries. It's debatable whether or not they're actually true branches of the aorta. Some people call them first, some people wouldn't call them branches at all. First branch you then get is the brachiocephalic trunk on the right-hand side, which becomes the right subclavian and the right common carotid. Then you get the left common carotid and the left subclavian. These then obviously go on to supply the head, neck, and upper limbs. They don't become too relevant in vascular surgery because most vascular conditions, acute and chronic, tend to affect the abdomen and the lower limbs. But they're worth being aware of, obviously, anyway. Then you get the descending aorta. There are no major branches of the descending aorta, but what often get missed from diagrams, and what you can't see here, is at every rib level, so right the way from the T1 down to T12, you have intercostal arteries branching off. These aren't majorly important in day-to-day life, but sometimes if you have acute aortic pathology, these get implicated, so you end up with neurovascular symptoms in dermatomes underneath the ribs where you've got injury to these small subcostal branches. It also penetrates through the diaphragm at the level of T12 for the aortic hiatus, the most inferior of the 3 hiatuses through the diaphragm. And then it becomes the abdominal aorta. You can see here a nice detailed diagram of all the different branches of the abdominal aorta. So there are 5 that are really worth being aware of. So the first 3 are the ones here in bold: celiac trunk, superior mesenteric artery, and the inferior mesenteric artery. These respectively supply the midgut, the foregut in the case of celiac trunk. So that's stomach, duodenum, liver, spleen. The midgut in the case of superior mesenteric artery. So that's everything from the jejunum, ileum, cecum, ascending colon, transverse colon. And then the inferior mesenteric artery at the level of L3-4, which comes off to supply the descending colon and the rectum, traditionally. You can get away, as you'll see later, with out any blood supply going through the inferior mesenteric artery. It's one that's often implicated in trauma or after vascular surgery. And it doesn't tend to matter too much because you get enough of a collateral supply coming from the superior mesenteric artery and other branching arteries but the superior esoteric and the celiac trunk are very important. The other two major branches to be aware of in the abdominal aorta are the renal arteries. You've got two, you've got the left and the right. These come at the level of L1, L2, and again, they become significant for aortic pathology when we look at aneurysms, because if an aneurysm is at or above or below the level of the renal arteries, strongly dictates the kind of management you can do. So then bifurcates at L4, as you can see here, a nice way to remember that is you've got the bifurcation point into the left and right common iliac. Those left and right common iliacs then each respectively bifurcate again into the internal and external iliac arteries. That brings you to the lower limb. So lower limb is probably the other major point where you get vascular disease that you will see in vascular surgery on the vascular wards. And vascular surgeons like it if you can remember the different segments. So here's how I remember it. You start off with the external iliac. This passes under the inguinal ligament to enter the femoral canal, at which point it then becomes known as the common femoral artery. And I think this is the bit that people tend to forget, is the difference between the common femoral artery and these two branches of the common femoral artery. There's profunda femoris, so profunda, Latin for deep femoris, it just means deep femoral artery, but for some reason we only ever use the Latin name and never the English name. Profunda femoris and the superficial femoral. The profunda femoris supplies the head of the femur. It gives rise to the lateral and medial circumflex arteries of the femoral head. And it tends not to be implicated in vascular disease, chronic or acute. It tends to be unaffected. Superficial femoral artery, however, very important for vascular disease, as it very commonly gets atherosclerotic and is a point for thrombosis, and where a lot of thromboembolisms get stuck. So this then travels through an area called the adductor canal, because it runs over the top of the adductor muscles in the thigh, underneath the sartorius muscle, exits through the adductor hiatus and becomes the popliteal artery. So this is in the area behind the knee, runs posteriorly to the knee. Popliteal artery then splits off into two initially. So it continues down the leg as the tibio-peroneal trunk. Part of it splits off and passes through the syndesmosis. So the syndesmosis is the interosseous membrane between the tibia and the fibula. So it penetrates through that membrane and then runs anteriorly down the leg. Tibio-peroneal trunk then splits into the peroneal artery and posterior tibial artery. So effectively from the popliteal, you have these three branches: anterior tibial, posterior tibial, and peroneal. And often in vascular surgery, this will be called triple vessel runoff. So when you're looking at a CT scan and surgeons talking about triple vessel runoff, those are the three arteries that they're talking about. And finally, when you're palpating for pulses, one of the ones you always need to check for, dorsalis pedis. So this is the final branch, or I guess this is what the anterior tibial artery becomes when it enters the foot. And if you can remember that structure, that will see you through all the vascular quizzing that you will ever need to know in theatres or on the ward. So acute vascular pathology. These are the sort of major areas of acute vascular pathology that I want to focus on. So you can have blockage, that's acute limb ischemia. You can have wall defects, so aneurysms, dissections, and pseudoaneurysms. And then you can have bleeds, and bleeds can come in the form usually of ruptured aneurysms or trauma. So acute limb ischemia, 6Ps, everyone knows the 6Ps. It's one of the things I think that really gets drilled into your head in preclinical years. But you don't actually get all of them at once. This is something that I think often isn't focused on in teaching. So yes, you get pale, pulseless, painful, and perishingly cold, but the other two, paresthesia and paralysis, those don't appear till later. So what happens in acute limb ischemia is you get a sudden blockage of blood flow going down to the limb, and this can usually happen for two major reasons. One, you have a plaque rupture. So this is like in a heart attack where you have an atherosclerotic plaque, the top of it ruptures, exposes the middle, the underneath, which then forms a thrombus. That thrombus occludes the artery. Or you can have a thromboembolism. So this is a bit like where you've got a stroke, where it's someone maybe with AF has clots forming in the atria that gets shot off through the circulation and embolizes and ends up blocking one of the arteries. And as soon as you get a blockage of the artery, right, you've got no blood coming in, so it's pale. The arteries occluded, so it's pulseless. The tissue is beginning to get ischemic, so it's painful. And it can't metabolize, so it's perishingly cold. The paresthesia occurs when you get ischemia of the small nerve endings. So it's a much later sign and a worrying sign because it indicates that you're beginning to get ischemia, a little bit of nerve ischemia. Paralysis is the same. You only get paralysis when you end up with really significant ischemia of the muscle and of the nerves, and that is usually irreversible. So these two are later signs, and they are absolute major red flags compared to the others. They're all red flags, but those two in particular. So how do you manage acute limb ischemia once it's been identified? Early management, early recognition is really important. And part of that is a vascular review. So urgent vascular review is always required. In the meantime, if you were the unfortunate F1 who got this patient landing in front of you, analgesia, so this is normally in the form of paracetamol and codeine, and heparin to try and maintain any clotting process that might be going on and prevent further thrombosis. In terms of the investigations you want to do, handheld Doppler should be done to assess for the pulses. And if the pulses are then present, you should try and do an ABPI to assess if there's any sort of background chronic vascular disease. You can also consider grading the symptoms you got in front of you. So this is the Rutherford grading scale of acute limb ischemia. There's also a Rutherford grading of chronic limb ischemia, but this is a Rutherford grading for acute limb ischemia. And there's 3 grades, with grade 2 being split into grade 2 and 2A and 2B. So grade 1 is mild, so you've got no sensory deficit, no motor deficit. The arterial and venous signals are both audible on a Doppler, and there's no immediate threat to the limb. 2A, you've got minimal sensory deficit. There's no arterial signal, but there's no motor deficit, and the venous signal is still audible. This means the limb is probably still salvageable if you can treat it promptly enough. 2B, there is sensory and motor deficit present. Arterial signal is inaudible, but you can still hear a venous signal, and the limb is salvaged if you treat it immediately. And grade 3, you're in serious trouble because you've got profound paralysis, no signals, and this is a sign that irreversible ischemia has already taken place. How to manage this surgically when the vascular surgeons do come review, what sort of options are they looking at? So if it's grade 1 or grade 2A, it can usually be managed conservatively or with surgery if they think it's indicated. But grades 2B and 3 have to be taken a bit more seriously. So if it's 2B or 3 and symptoms have been there for more than 6 hours, you've got to assess have symptoms been there for more than 6 hours, and is there any clinical signs of irreversible ischemia? If no, then these are your options. You can do an embolectomy. So this is where you go in through an artery. You go in with a little wire that's got an inflatable balloon on the end. You take it through the clot, inflate the balloon, pull it out, and it's just plumbing. It just pulls that clot out. It's literally just plumbing. You can do local thrombolysis, which is again is when you go in locally to the artery and just inject your thrombolytic drugs directly to where the thrombus is. Or you can consider a bypass operation. So we'll touch on bypass operations later when we look at chronic limb ischemia. If the answer to that question, however, is yes, so if the symptoms have been there for more than 6 hours and there are signs of irreversible ischemia, you have to amputate. And it may seem quite extreme, but there is a reason for it, and that is because of reperfusion injuries. So reperfusion injury, what's going on there? When you've got ischemia to the limb, you begin to get tissue breakdown. So skeletal muscle can usually last 6 hours without oxygen before you start to get significant tissue breakdown, which is why that window of 6 hours is so important. When this happens, you get a release of all the intercellular contents into the extracellular space. So this is your potassium ions that are normally held in the cell. This is your hydrogen ions, which are normally in the cell. And this is all the myoglobin, which forms the bulk of the skeletal muscle cells. When you then get reperfusion of the limb, this causes a rapid increase in capillary permeability. And this causes 2 things. One, it flushes all of this potassium, hydrogen, and myoglobin out into the bloodstream. And this causes arrhythmias, hyperkalemia, known to cause arrhythmias, acidosis, because you're obviously adding loads of extra hydrogen ions to the bloodstream, and AKI, because all that myoglobin gets stuck in the glomeruli and shuts down the kidneys. And this can very rapidly lead to death. The other thing it does, if you're increasing the capillary permeability and you've got a sudden flush of blood coming in, this increases the pressure within the muscular compartments in the leg. And so you also get compartment syndrome. So it's a 2-for-1. You have whole body shutdown, basically, and extreme agony. Which is why, yes, it seems extreme to amputate the limb if you think there's ischemia, but it's better than having someone dying in complete agony. Such are the joys of vascular surgery. So that's acute limb ischemia. Now on to vessel wall defects. This diagram actually shows it really nicely. So on the left, what you see here is a healthy artery. So you've got 3 layers. You've got the tunica intima, tunica media, and tunica adventitia. The first type of wall defect you can get is an aneurysm, true aneurysm. Aneurysm is just defined as a dilation of a blood vessel beyond its normal diameter. So it can be saccular or fusiform, as you see there. Saccular tend to be within the brain. These are your berry aneurysms. These are the ones you get in the neurovasculature. Fusiform tends to be what you get in the peripheral arteries. And as you can see there, it's a dilation of all three vessel wall layers at the same time. It's essentially a weakening of the wall that causes it to balloon because you get a loss of that rebound elasticity that normally keeps the structure. And you can also have a dissection, so people should be aware of what aortic dissections are. Tends to not be a vascular surgical condition, tends to be dealt with cardiothoracics or medically if it's a type B descending dissection. But what you get here is you get a defect in the tunicate intima, and then blood pools between the layers of the wall vessel. So you're not getting a dilation of all three layers, you're getting a dilation of the outer layers and blood creating a false lumen between the two layers. So you can see here, particularly bad aortic dissection. That's your false lumen sign there. And that was the intima. And now you've got blood on both sides and it's formed a true lumen and a false lumen. It's different from from an aneurysm. It tends to present very acutely because it's essentially a form of bleed. The third kind of vessel wall defect, which again is something you do see a lot of vascular surgery, is a false aneurysm or pseudoaneurysm. So this occurs when you get a puncture defect through all three walls of the blood vessel. And the commonest times you see this is in IV drug users. The IV drug users who've, particularly in the groin, been looking to get into a vein, usually the femoral vein, missed and hit an artery, and their needle's gone right through all layers. Or in hospital when you've patients have been referred for angiograms, stenting, things like that. And the cardiologist, interventional radiologist, vascular surgeon, whoever has gone through and not applied proper pressure afterwards, and then blood has escaped outside the blood vessel and forms a localized hematoma. And there are multitudes of problems you can get with this. So one is when you have this hematoma formation, this can actually swell to a point where it compresses the blood flow, and sort of cause symptoms of limb ischemia because you're obscuring the blood flow. But also what it can do is if you've got a tract that's been running from the skin into the blood vessel and you've got this hematoma that's breaking down and running between the two, is it's a perfect source for infection to track its way into deep tissues. And so again, I've seen cases on vascular wards where people have had these open groin wounds that have been slothy and falling apart and full of necrotic tissue because of a stent. A cardiologist has gone in to put a stent and not applied proper wound care afterwards, and it's called a pseudoaneurysm. Those are wall defects. The most common one that you get in exam questions is a AAA, abdominal aortic aneurysm. You can see here, I mentioned the importance of the renal arteries. So you can see here, this is kind of around the level of the renal arteries. This would be juxta-renal aneurysm. And the questions I sort of love to ask in exam are all questions about AAA screening. So just to be aware of what the AAA screening program is, every male at the age of 65 will be invited to screening. Why males and not females? Estrogen is actually known to be protective for aneurysms. So for whatever reason, estrogen protects muscles from becoming aneurysmic. There's also a behavioral element as well, where male patients are more prone to risk-taking behaviors such as binge drinking and smoking, which will predispose to aneurysm formation. So at the moment, it's only male patients. Invited for a one-off abdominal ultrasound. If their aorta is less than 3 centimeters, that's normal caliber, they're discharged, their risk of getting an aneurysm in their lifetime, the risk of dying from an aneurysm in their lifetime is so minimal that there's no follow-up needed. If it's 3 to 4.4 centimeters, they're invited for a rescan every 12 months. If it's 4.5 to 5.4, they're invited for a rescan every 3 months. So the 3 to 4.4, those are your small aneurysms. 4.5 to 5.4 are your medium-sized aneurysms, so you want to bring them back slightly more frequently. And if it's above 5.5 centimeters, then they're referred for surgical repair. A lot of aneurysms are picked up incidentally outside of the screening program, but the same rules will apply. If an aneurysm is picked up, they'll be referred for routine surveillance, even if it wasn't picked up by the screening program. So additionally, if the aneurysm is growing by more than 1 centimeter per year, or it becomes symptomatic basically always means back pain, they are referred for aneurysm repair. So what's the management of AAA? So all patients are offered lifestyle modification and risk factor modification would probably be a more accurate thing to say. So this is stop smoking. They always smoke. Got to tell them to stop smoking. Blood pressure control, that reduces the risk of perforation, of rupture. statin, weight loss, exercise, and if it's relevant, diabetic control. There's no one sort of specific intervention that you do. You do it on a patient by patient basis based on which risk factors they have and what you can modify. If they are referred for surgical repair, these are the two options that are weighed up. So endovascular aneurysm repair, that's EVAR, or an open repair. So EVAR tends to be preferred in elderly patients because it's endovascular, you just go through the groin. So it's minimally invasive, very short hospital stay. You're not going all the way through someone's abdomen. So your frail patients will tend to get this. Short-term outcomes are basically exactly the same between EVAR and open. So if you don't have to do a big open operation, why would you do a big open operation? Open repair tends to be favored in younger patients because it's believed that it's got better long-term outcomes, fewer chance of it's called an endo leak, where you get leak going around the graft. But you can see here, I mentioned earlier about the inferior mesenteric artery. If you look at this diagram here, you can see that the inferior mesenteric artery has been sewn shut, and that is fairly common. You can also see, and this is true to the procedure, that in order to get access to the aneurysm and repair it, you have to put a clamp across the aorta and clamps across the iliacs. This is obviously you're clamping the iliacs, so nothing downstream of them is getting any blood supply at all, and you're clamping the aorta, which is applying a lot of back pressure to the systemic circulation. So it takes a huge physiological hit on a patient. It's a big operation. They almost always need blood transfusions as well, almost always associated with a fairly significant blood loss. So they're less common now. Most aneurysms are repaired through EVAR. About 70%, I think, are repaired through EVAR these days. But those are the two ways of repairing. What happens in a ruptured AAA? This is talking about acute vascular disease. This is the classic acute vascular emergency. How it presents, you have a triad, you have back pain, hypotension, pulsatile, and expansile mass. This is what you get in an exam question. Rarely do patients, well, I say rarely, only about half of the time do patients actually present with all three of these symptoms. What to do if you think you see one. So the imaging, if they're unstable, so that means blood pressure is tanking through the floor, death is looking imminent. You don't even bother imaging. You diagnose clinically, you take them straight to theatre, bleep the on-call surgeon, they need an operation. If they're stable enough and you think you've got, a few hours to prepare a management plan, then a CT angiogram is the investigation of choice, but only if they're stable and you think that they will benefit from having a CT. In terms of what you need to give them, if you suspect a patient has a ruptured AAA, high flow oxygen is important. If you think you've got a massive bleed, you don't want them getting hypoxic, so ensuring oxygen and saturations remain high. Large bore cannula, these patients will almost always need blood transfusion. So a large bore cannula through which you can give blood, or indeed rapid fluid boluses are important. Take off bloods, group and save, cross match, coag, plus all your standard admission bloods that you do for any other patient, and you get them in for surgical repair. Now, I mentioned large bore cannulas for fluids. You have to be careful. So there's this thing called permissive shock and the tamponade effect. What you can see here is this is very typical of AAA. You've got this big aneurysm here, and it's bleeding out into the retroperitoneal space. So 80% of AAAs, when they rupture, will bleed into the retroperitoneal space. 20% will bleed into the peritoneal space. And what happens is when the retroperitoneal space fills with blood, it forms big hematoma, but you also get this big tamponade effect, so it can only fill up so much. So it's like the cavity is applying a sort of pressure to keep the bleeding shut, which can stabilize the bleed, which can stabilize the blood pressure and stabilize the patient's condition. It's thought that keeping the systolic blood pressure below 100 will actually keep this stable. So if you increase the blood pressure too high, that can dislodge the hematoma that's formed. If you dislodge the hematoma, you rebleed, you then get more blood going out into this space. So permissive shock is what's this called, keeping the blood pressure relatively low. And actually, it's so important that when you're preparing patients for surgery, you actually clean and drape the patient while they're awake, very unusually. The anesthetic isn't given until you are literally making the incision with the knife, which is quite unusual and fun for surgeon and anaesthetist alike. So arterial trauma is the other thing that causes bleed. This is, variable presentation. It can literally be anything, but classically, it would be stab wounds, gunshot wounds, major traumas, car crash accidents, but also, old fragile old ladies falling down and having open fractures can cause this. And the management's really decided by a multidisciplinary team. So, as I say, if you've got an elderly lady who's fallen over, she's got a nasty tibial fracture, and you've completely lacerated one of your tibial arteries, if the other one's fine and the foot is being perfused and you've got a decent cap refill time, often they just won't bother doing anything. They'll look in, they'll say you've still got a perfused limb. Um, Traumatic repair or repair of trauma to arteries is normally only done if there's no collateral circulation to the end target organ. And this also doesn't come up in exams either. So ulcers, here is a very quick one slide overview of the different kind of ulcers you can get. So arterial ulcers, these occur over distal sites where you've got pressure and occur due to poor blood supply. They tend to be small, deep, and with a necrotic base. So what happens is you get pressure on an area or you get injury to an area. There's no blood getting there, so there's no white cells getting there. So it can't heal, so it just stays in this injured state. And because there's no white cells to sort of help form this granulation tissue at the base, it just gets necrotic. Venous ulcers, sort of the opposite of arterial ulcers. So they classically occur in the gaiter region, which is basically the medial thigh, medial malleolus, essentially where you get them. And they are wide, shallow, and do have this granulation tissue base because the white cells that need to form that granulation tissue can still get there because you don't have an arterial problem. The problem is from chronic venous disease, which we'll get to later. And the third type of ulcer you can get is a neuropathic ulcer. So these are usually secondary to diabetes. They tend to be over the metatarsal head, so ball of the foot or the heel, where you've got a lot of pressure going on. And they have this punched out appearance. And they're completely painless. I mean, you might look at that and think, God, that looks painful. But they're there because the patient has had an injury and just completely not felt it at all. They also tend to be associated with because you've got peripheral neuropathy, you get other signs of peripheral neuropathy like Charcot's foot. So those feet are relatively normal looking for a patient with peripheral neuropathy. Normally you get this deformation. Additionally, going back to the arterial ulcers, you often get them on the most distal sites, so on the tips of the toes, which helps differentiate them from a neuropathic ulcer, where you don't have much pressure on the tip of the toe, whereas you do have pressure on the balls of the feet. Chronic vascular pathology. So in this section, I'm going to look at claudication, chronic limb ischemia, chronic limb-threatening ischemia, and chronic venous insufficiency. So a quick word on terminology, because this is being very nitpicky and very particular, and for most people you speak to, it won't matter, but it's worth being aware of. So people will often say peripheral arterial disease, but peripheral arterial disease is an umbrella term. So if you think about what it means, a peripheral artery is any artery that's outside the brain, outside the heart. So if you've got something like mesenteric ischemia, ischemic colitis, that's peripheral arterial disease. If you've got the acute disease we were talking about earlier, acute limb ischemia, that's peripheral arterial disease. What people are normally referring to when they say peripheral arterial disease is chronic limb ischemia, but the terms are used interchangeably. And when you're talking about chronic limb ischemia, the two most common subtypes you often talk about are intermittent claudication and CLTI, chronic limb threatening ischemia, which used to be known as critical limb ischemia. Some places, for example, I know on the PassMed textbook, they still call it critical limb ischemia. That's an outdated term. That's not used so much in modern vascular setting. So claudication comes from the Latin word claudicare, which means to limp. It's like angina in the leg. So it's ischemic pain brought on by exertion and alleviated by rest. So this is quite a nice diagram actually that shows you the sort of pathophys of claudication, because the site of the pain is entirely dependent on where the obstruction, where the blockage, where the stenosis is. So if they've got calf pain on exertion, well, usually that's a superficial femoral artery. As I said earlier, superficial femoral artery, very prone to vascular disease. If it's in the thigh, it's often from the common femoral or common iliac, buttock, again, aorto-iliac disease, so from the distal aorta or the common iliac. The trick, or the thing they like to try and trick you out with in exams is leg pain brought on by exertion and relieved by rest. The other differential you need to have is lumbar spinal stenosis. It presents sort of similarly, but the actual pathophysiology going on is very, very different. So lumbar spinal stenosis is nerve impingement. So it's a different kind of pain. This is ischemic pain. It's more, I don't know, like achy, burny pain, and patients might say, as opposed to the nerve entrapment pain, which tends to be more shooting pain. But the classic hint that they'll give you to differentiate is that lumbar spinal stenosis improves as soon as someone sits down or bends forward. As soon as you're doing that, you're creating space in the spinal canal for the nerves and you're removing that impingement. But that's not going to do anything for your intermittent claudication patients who have ischemic muscle, and the issue is in the blood supply in the muscle. So that's usually what they are looking for in the exams. So the other type of chronic limb ischemia that you very commonly come across is chronic limb-threatening ischemia, CLTI. So this is defined as a patient with any one of these 3 points. So ischemic rest pain lasting more than 2 weeks. So unlike claudication, it's brought on by exercise. This will be pain just lying in bed, sat watching TV, constant pain. A non-healing ischemic injury, so that's an ulcer or gangrene, or an ancobrachial pressure index of less than 0.5. So if they have any one of those 3 symptoms, they can be diagnosed with chronic limb-threatening ischemia. So what investigations do you do for patients with chronic limb ischemia? And this goes for both your claudicants and your chronic limb-threatening ischemia patients. So the first investigation is an ancobrachial pressure index. It's worth being aware that you can see this table on the right-hand side there, looking at different gradings based on ABPI. So normal being greater than 0.9, mild being 0.8 to 0.9, moderate being 0.5 to 0.8, and severe being less than 0.5. So severe, that's equivalent to CLTI. But you can very much get false negatives, particularly in diabetic patients who have extensive calcification of the arteries. Because if you've got extensive calcification of the arteries, you've got these hard plaques. These arteries are hard, they're very difficult to compress with blood pressure cuff. So you have to inflate the cuff to a higher pressure to occlude the artery and get a reading. So you end up with, sometimes it'll be more than one, so they might have 1.1 or 1.2 as an ancobrachial pressure index. They've still got very poor blood supply to the leg, but because the arteries are hard to occlude, they have a false negative on the ABPI. So in these cases, you want to do a toe brachial pressure index. So it's exactly the same thing. Cuff, but instead of on the ankle, it's on the toe. You measure the toe pressure, you do it as a ratio. There's slightly different set of values for that. So if you're looking at toe pressures, then less than 0.3 is diagnostic of CLTI. The one thing you do when you do the ABPI is a Doppler ultrasound assessment. The second line investigation you want to do is a duplex ultrasound assessment. What's the difference? Because I find this something that I frequently get wrong in the exam. So they both utilize the same effect. They both utilize the principle in physics called the Doppler effect, where you're measuring the change in wavelength of a wave when it reflects off something in motion. But they use that data in different ways. So a Doppler ultrasound it looks like a little radio, a tiny little probe. You put it, and you only get a sound. So you get a whoosh, bulb of an artery when you place it over the right point. Whereas a duplex ultrasound, and I've fucked up the slides, I put Doppler there. It should say duplex on the bottom point. I apologize. A duplex ultrasound is an image, so you get an actual ultrasound image, and you can measure blood flow and get a waveform. And you can still get the same data from a Doppler that you get from a duplex, but you get additional imaging. The thing is, it requires a trained ultrasonographer, so it's a bit more specialist. You'll have to call someone in to do it. It's not immediate. Whereas if you've got a Doppler ultrasound probe, you can just do it bedside, immediate investigation. So the Doppler you do to help diagnose, and the duplex you do to help come up with your management plan, if that makes sense. So the duplex ultrasound is the first investigation you do for your management. The Doppler and the ABPI is the first measurement you do for your diagnosis. If you've not got enough information from the duplex ultrasound, then the next investigation to do decide the management of chronic limb ischemia is a CT angiogram or an MR angiogram. So, right, you've got the data, you've diagnosed them with chronic limb ischemia. How do you manage them? So, all patients need lifestyle modification. That's the same as with the aneurysms. Smoking cessation, regular exercise, weight loss, lipid modifications, that's usually statin, and antiplatelet therapy, which is almost always clopidogrel for these patients. And consideration of surgical management. So, in simple intermittent claudication, there have been lots and lots and lots of trials on this, on can we improve long-term outcomes by offering surgery early in people with intermittent claudication? And the resounding answer is no. If you look at in cancers, you'll look at 5-year survival rate. So what's the mortality after 5 years? In vascular, they do that, but they also look at 5-year amputation-free rate. So what proportion of patients 5 years down the line still have both their legs? And it's been found that if you offer surgery in intermittent claudication, simple intermittent claudication with no other symptoms, they have a higher risk of amputation within the next 5 years than patients who are managed conservatively with statin, antiplatelet, and exercise. So you don't tend to operate on the intermittent claudication patients. In chronic limb ischemia, it's a little bit different. These patients are the patients with rest pain, the patients with constant pain, the gangrene ulcers. These are patients who do definitely benefit from surgery. And there's a score that they use. This is beyond the scope of UKMLA or med student exams or what you'd be expected to know. There's a score they use called the Wi-Fi score. So that stands for wound, ischemia, foot infection. So it looks at the wound, it looks at the degree of ischemia, it looks at grading any foot infection. And based on the Wi-Fi score, that will tell clinicians whether they need to consider surgical management. So if you do decide for surgical management, these are the options available. So if conservative management's failed, so exercise, weight loss, etc., has failed, the first thing you'd want to do would be angioplasty because it's the least invasive, most cost effective, short hospital stay, very small physiological hit. So this is just going in with a wire with a balloon on it, expanding the balloon. The balloon expands the artery, pushes the plaque back, increases blood flow. But you can't always do that. So you have to look at the stenosis segment length. So again, this comes from the NICE guidance, and this comes from what gets asked in exams. The sort of general rule is if it's less than 10 centimeters, you can consider angioplasty. But if it's more than 10 centimeters, you can't do that with a balloon, so you should consider bypass surgery. And then if angio fails, if it's less than 10 centimeters and you have managed to do an angioplasty, and that fails, you consider a bypass. The real world is a little bit more complicated than this. So in the real world, they use something called a glass score. So this is another one of these scores that has recently come out and has been validated, which takes into all different elements of the patient's anatomy, and that's usually what's used to decide whether someone has an angioplasty or a bypass. But general rule of thumb, less than 10 centimeters angioplasty, more than 10 centimeters bypass. If bypass fails, and bypasses do fail, they fail a lot. They thrombose, they clot, particularly if they get infected, and particularly if patients don't stop smoking. Then you have to progress to an amputation. And this is what you'll see all the time on the ward. It does not say it happens to all the patients. It's just all the patients you see on the wards will be the ones who've had these failed bypasses. So that's vascular arterial disease. A quick word on venous disease and venous insufficiency, because it's probably more common. So if you're in GP particularly, this is what you will see a lot of. But there's less surgical management, so it's less what you'll see less of this on a vascular ward, but more of it in the community. So the pathophysiology, what happens? You have a loss of function of venous valves. Without venous valves, you get retrograde flow. So you can see this on an ultrasound. You get backflow of blood through the veins. This then, you've got blood pooling in the veins. For one, you get varicose veins. You get these dilated, swollen veins that become visible on patients' lower legs. But you also get increased pressure in the venous system. So an increased pressure in the venous system, if you remember from your preclinical years, the balance between hydrostatic and osmotic pressure. In an arterial bed, so in a capillary bed, on the arterial end, you've got blood pressure, the physical pressure of the blood. This forces fluid and it forces other things out into the capillary bed. But as you get more towards the venous end, the pressure reduces, and you have this osmotic pressure from predominantly albumin, which draws everything back in. But when you've got pooling of blood, you increase the hydrostatic pressure at the venous end, and so this osmotic effect is reduced, so you get edema, and it's often might be misdiagnosed as heart failure because you get it in elderly patients who sometimes will have an underlying heart failure, but peripheral edema can also very commonly be caused by chronic venous insufficiency. Then that continued pooling of the blood, you end up with cell lysis. You get cells that aren't moving anywhere. These cells break down, and you get localized inflammation. This causes a lot of things. So the breakdown of blood cells, red blood cells, causes hemosiderin deposition, which causes pigmentation and discoloration of the skin. But the inflammation you get, it's not just in the veins, it seeps into the subcutaneous fat and subcutaneous tissue. And chronic inflammation of the subcutaneous fat causes something called lipodermatosclerosis. And if you think about what that means, lipo, fat, dermatoskin, sclerosis, it's this sclerotic, thick, hard, scaly skin. And this can lead you to another stage of venous disease where actually you stop getting edema at the periphery because the skin has become so hard and sclerosed that it won't swell. But above that level where you've got the lipodermatosclerosis, you still have continued edema. So it's called a champagne bottle sign because the patient's lower legs start to look like upside down champagne bottles with these narrow necks at the bottom and then wide, very edematous upper calves. And this continued inflammation will eventually lead to ulceration. And this is how you get those venous ulcers that we saw earlier. So what do you do? Well, if you want to investigate, you do a venous Doppler ultrasound, and you can also do a venous duplex ultrasound. Ultrasound, that's what you do for the veins, basically. The management depends on whether they've got ulceration. So if there's no ulceration present, then you could want to do compression stockings. So much like VT prophylaxis, compression stockings will apply pressure to those veins. It will force the blood up. So it's not static anymore. It doesn't have that pressure. You alleviate the pressure, you alleviate the swelling, you get that blood flowing again, and you stop the progression of symptoms. And elevated legs. Sounds really simple. If you just elevate a leg, that's going to increase venous return. Now, interesting point here to consider. This only works if you don't have concurrent peripheral arterial disease. Because if you've got peripheral arterial disease, blood is struggling to get down into the leg. So patients will say that their pain is better when they're sitting on the bed and they've got their legs dangling over the side because gravity is helping to pull that blood down past the stenotic artery. Now that's the opposite in venous disease. In venous disease, there's too much blood pooling and you want it to return. So patients say it's better with their legs up. Likewise, with arterial disease, there's too much, the blood is really struggling to get through these arteries. If you compress them with compression stockings, then that's just going to make it even harder for the blood to get through these arteries. So that can worsen peripheral arterial disease. The treating chronic venous insufficiency, you've got to be careful that there's not some significant arterial disease going on there earlier because it would be very, very counterproductive. You can't really treat both at the same time. If there is ulceration, you don't use compression stockings, you use compression bandagings. That's the next step up. Yeah, higher pressure, but also you're protecting any open wounds. You're keeping them protected from the environment and not getting them exposed to bacteria and dirt. As you can see here, this is a nice diagram sort of showing the progression of venous disease. So those spider veins are the very early signs you're getting venous congestion. Progress to varicose veins, the chronic insufficiency, you get the lipodermatosclerosis, discoloration, which eventually progresses to ulceration. That's a very, very quick whistle-stop tour of vascular surgery. Any questions or anything that I didn't cover?
I think so. That was really good. I'm gonna try and impress my surgical supervisor. I'm gonna go study all of this over Christmas. And when I come back, she'll be like, "Oh my God, how do you know so much vascular?"
Who's your supervisor? Is it
Such a good question.
Miss Condra?
She already emailed us in September.
Oh, wow, that's preparation.
I know, like pairing us up with F1s as well.
I think I will end the Zoom call there.
Candolas, Santo Candola.
I'm sorry, Nikita, if you want to ask questions, you can put one in the chat or
Oh wait, till you start.
No, Nikita say it though. Yeah, I'll end the Zoom call.